Okay, so yeah, I'm back again. Hopefully this is not going to be too dull. I hate talking at the last session of a day because everybody's done. And with the heat in this room, I'm sure everybody's going to be falling asleep. So this is all about safety reporting and adverse events in clinical trials. So what I want to do here is talk again very briefly about GCP. Then what I'm going to show you are some algorithms that I think, personally speaking, are useful for evaluating whether something is or is not an adverse event. These are kind of done, it's what I use for training our staff in Galway and have done for a number of years. And then depending on time at the end, we have a couple of kind of cases that we can work through. If I have rambled far too much, we will skip the cases. So feel free to interrupt. So going back to GCP, the definition of an adverse event. So the first thing is it's an untoward medical occurrence. So the word untoward means that it was not expected. Right, that's really important. That word is really important, and people forget it all the time. So it means it's not planned or expected at the time the patient was consented into a study. An adverse event can be a new condition, a symptom, a worsening of a baseline condition, a laboratory abnormality, an investigational abnormality, or just a clinical thing that a person or a patient feels themselves, even if you don't ever do anything else. From a GCP perspective, it occurs in a patient or a clinical trial subject who's been administered a medicinal product. In practical terms, that includes ATMPs, so the stem cells, and the definitions are quite similar when it comes to clinical devices or clinical investigations. There's slightly different acronyms, but the general principles are the same. It does not necessarily have to have a causal relationship with the treatment. So for everybody at site who is sick of talking to investigators to say just because it had nothing to do with the drug or the study doesn't mean it has to be reported, it usually does. So the person who gets hit by the bus that I mentioned earlier on, that's an adverse event. It might have nothing to do with the drug, but it's still an adverse event, unless the clinical trial protocol exempts it. So it is study dependent. So as I've said, an adverse event term, which is usually the description of what's going on, it can be a symptom, a diagnosis, or a clinical syndrome. That will vary depending on the phase of the trial. So I've worked on phase 1 trials where we're giving an injectable therapy, where they wanted a separate adverse event for redness at the injection site, soreness at the injection site, bruising at the injection site, elevation at the injection site, hardness at the injection site, all occurring in the same person. Whereas in a phase 3 trial, the same thing might say an injection site reaction. So the study-specific training will tell you what level of detail they want, and there may be particular events of interest. It's important that you determine seriousness, severity, and causality, right? So they mean different things. Seriousness and severity are not the same thing. They have quite a specific definition. I'm going to come back to them in the next slide because it matters as to whether something is or is not a serious adverse event. Severity and causality are usually things that have to be documented by a clinician, no matter by whoever the investigator is or a sub-investigator is. The date of onset of an adverse event is usually when the patient felt the symptoms first or had a diagnosis. So somebody who had pneumonia who wound up in hospital 4 days later, the onset of the pneumonia was 4 days ago, not the day they went into hospital. But their hospitalization date is obviously there. And I'm going to come back to this a little bit in the cases. It's really important that there's proper investigator oversight of potential events. Remember I mentioned earlier about documentation. It's important that at site, so if you're seeing patients and you're collecting information and say, oh, this person has had this happen to them, I don't know if it's an adverse event or not, or I think it might be an adverse event. You go and talk to the investigator, and the investigator says, yeah, that's not an adverse event. Rightly or wrongly, but we'll assume they do know what they're doing in this particular instance. They need to document that. They need to actually write down and say, I have looked at this and I've determined it's not an adverse event because. Right? And the reason this is a problem is if you end up having a competent authority inspection or a monitoring visit or something where somebody who does know what they're talking about reviews it, if you don't document that assessment, there's no evidence that the investigator was even aware it occurred. So there's an automatic kind of suggestion when you report an adverse event that an investigator was involved because they're going to have signed off on some form, in some shape or form somewhere. But the event that wasn't relevant, they do need to sign or document it. And that comes back to an issue of investigator oversight. So I had an example in a trial, a dialysis-based trial we did in Canada, where there was a phenomenal research assistant who was working on the study, who'd been working on dialysis studies for 2 years at the time, was not a healthcare professional of any description. right? So had a BA and in background, had not worked with patients before, went into research, had learned everything on what he was doing within the job, and got used to knowing what happens with dialysis prescriptions, and got used to knowing what was going on with dialysis medications and all of those things, and said, oh yeah, I noticed that happened, but that just happens all the time. That's not an adverse event, it's not a clinically significant thing, so I didn't tell the investigator about it. So he was correct that it wasn't an important occurrence and it wasn't an adverse event. He was completely operating outside of his scope of practice. He wasn't delegated nor trained or qualified to make that assessment. And it can become really difficult at site level when you do know the answer to the question and you can't get a hold of the investigator who is the one who's actually qualified to do it. So in that instance, even though the action was the same, had we not identified it before the regulator came in, they'd have had a finding for investigator oversight because he'd effectively had site staff that were operating outside of the scope of practice. So serious adverse events have to meet the definition of an adverse event first, meaning they have to be untoward medical occurrences. Anybody who's trained in GCP, for the most part, with one or two exceptions here, can determine whether an event is serious or not. Because a serious event is either fatal, life-threatening, requires hospitalization, prolongs an existing hospitalization, leads to persistent or significant disability or incapacity, or causes a congenital anomaly or birth defect. That's what the definition is. So if you don't know anything about healthcare, but somebody says, I had a chest infection, I got admitted and they gave me antibiotics, you don't need to be a healthcare professional to interpret that that person was hospitalized. But if you're not a healthcare professional, you can't determine whether that was life-threatening or not, because that's a severity issue. The date of onset of a serious adverse event is not when the symptoms started, it's when the event became serious. So somebody who had that pneumonia, who was 3 days at home, didn't do well and wound up being hospitalised, the date of onset of their SAE is when they enter the hospital. The date of resolution of the SAE is when they leave the hospital or they no longer meet the criterion that's relevant for seriousness, but they might still have an ongoing infection that hasn't cleared for another 3 or 4 days. So it gets really messy and fiddly dealing with dates of onset, dates of resolution of adverse events, serious adverse events, when an event did or did not become serious, what criteria was going on, what has to be reported to the sponsor, and it can drive the site crazy. You guys asked me a question about what drives sites crazy or how can we make things easier. Make this as transparent as possible. Actually think about this and have somebody who has ever been involved in a clinical trial review your safety reporting process. So one of the things we do for some of our studies, rightly or wrongly, it's how we've chosen to do it, is if we have a change in seriousness criteria, meaning that pneumonia I was talking about, we ask the site to complete a brand new AE form. So what happens is the site will say, this pneumonia started on Monday. They were there for 3 or 4 days. We have, that pneumonia is still ongoing, but it became a serious adverse event. And we actually ask them to complete a new form as of the date that they enter the hospital. When they leave the hospital and if the event is over, we'll say that event has now resolved and they can close it off. If they were leaving the hospital and the event was not over, we'd ask them to complete a third form. And they're simple 1-page, very short, minimal data fields on the form. That way we can always look back and say, patient 1 in the trial had pneumonia on the 31st of March. They were admitted to hospital on the 3rd of April, they left the hospital on the 6th of April, and the event was over on the 10th of April. And we can do that from the database. We're not leading with a million different queries going, well, which date is that, and which one is it, and what's in the metadata, and what's in the answer to the query, and what's hidden in this part of the database, and what's there. It's a problem. It also becomes problematic if you try and have everybody do this in narrative summaries, because anybody who's ever worked on a trial that has more than 2 patients in it, or maybe even the 2 patients in it, will realise that you can't produce a report based on random paragraphs. So if you want to try and do this for a study that has 500 people, 2,000 people, 10,000 people, you need to have this as automated as possible to say, these are the number of events, this is where it's going to go. And we obviously have processes built in where we don't triple count that event. We know that's 1 pneumonia, we know that's 1 case. So when is an adverse event not an adverse event? So the protocol may list specific events that are exempted from safety reporting. A pre-planned hospitalization is one of those. So somebody who goes into your study who knew at the time they were going into the study they were going in 2 weeks later for a hip replacement. That's not an adverse event. It's not an untoward occurrence. That has been planned. We've known it's happening. Something might happen to them during it that would be an adverse event, but that's not the same. Expected consequences are things that make sense to happen, right? So this confused a couple of people in our centre when we started this, but that gestational diabetes trial I mentioned earlier on, most women are having their babies in a hospital setting. That's an expected hospitalisation when you recruit a pregnant woman into a study. So it's not an untoward occurrence. They're going to appear for delivery at some point in time in the study. So that's not a serious adverse event, right? Obviously, there are variations on a clinical perspective on that might be. But there are things like that make sense. The other thing is if you're interested in an endpoint, so cardiovascular prevention trials often will have cardiovascular death, they'll have myocardial infarction, they'll have stroke, and they'll have heart failure as an endpoint in the trial. If it's an endpoint, it's not entirely unexpected. So most of those events will not also be reported as a serious adverse event. They will actually have an event formed specifically in the dataset to say, here is all of the cases of heart attack, here are all of these things reported this way. And there'll be criteria built in to say, if one of these occurs and it's particularly severe or something particular happened that needs to be reported onwards, that's what we're going to do. So it is important if you're going to exempt something from safety reporting that you're still measuring it, that you're still counting it. That's why those event forms are there. So when an ethics board, a competent authority, a funder, anybody turns around to you and says, how many deaths have you had in the study? How many heart attacks have you had in the study? You can report that at any particular point in time. So I'm going to move in towards the algorithm piece of this to try and make it a bit less dry, I suppose, for want of a better word. I hate spending too long talking about GCP, even though I've spent a lot of today talking about GCP. The potential sources that I have thought of over the years, and I'm entirely open to people correcting me or adding things to this, is a patient has a new or a change in a symptom or a diagnosis. They go to a GP or an outpatient clinic, they go to be hospitalised, or they have a medical procedure. There's a laboratory or diagnostic abnormality detected somewhere, or there's a change in a medication. They are most of the clinical interactions where somebody might have had an adverse event. So what I wanted to do with these was to try and think through practically speaking, think through what they actually mean. So we've a new symptom, or we've a symptom or a diagnosis. The first thing to say, did this start before consent or after consent? Started after consent, almost always an adverse event or an exempted outcome. So for the rest of this, imagine there's no exempted outcomes for the study. It's there since before consent, right? It's not a new occurrence. Is there an acute episode? Is there a flare? Is there a worsening? Is something changed? Is something that's different? If that's the case, it's an adverse event. If it's the same as it always is, and there's been no action taken, it's probably not an adverse event. If there was an action taken, it may be an adverse event. So if the action is we're going to give you something to prevent something, so say we're going to give you a medication to prevent something happening, that doesn't mean necessarily that something bad has actually happened. So a lot of preventive prophylactic measures are not adverse events. Whereas if you're giving a significant change in a treatment, and this is a clinical judgment decision, which is why it has to be made by an appropriate person, that may or may not be an adverse event depending on how you think the condition is occurring. These will make more sense if I do actually manage to get through this fast enough to get to the cases, I hope. Somebody goes to a GP or they go to an outpatient clinic, right? So lots of people will pitch up to their GP to get their blood pressure checked. They'll go to an outpatient clinic for their long-established condition. If you go for screening, it's entirely asymptomatic. There's no complications from the screening and there's no new diagnosis. It's not an adverse event. So a woman who goes to breast check because they get called to breast check has no complications whatsoever from it. That's a routine occurrence. If you go there and they find something, that's an adverse event. If you go to a GP and say, oh, that's better, you've now lost a medical history item, it's not a new one, that's not an adverse event. If you go and say, I've had my 6 monthly blood pressure check, everything's fine, nothing's changed, no medication has changed, it's not an issue. There are certain medication things, I have a separate algorithm for it. If you go and have testing done, like somebody goes and say, I get my bloods done once a year, the outcome of that may be slightly different, so I'll show you that in another one. And if you've gone to a GP or you've gone to a clinic because you're feeling unwell, something's happening, something's changing, that is probably an adverse event. Does this make sense so far? I know it's still abstract. Hospitalizations, medical procedures. So if it's an emergency, right, I fell down the stairs, my leg fell off, I got hit by a bus, whatever. It's unanticipated, it's an adverse event, right? If it's an elective or a planned procedure, If it's planned after consent versus it's planned before consent makes a difference. So you have somebody who has a colonoscopy planned after they went into a clinical trial, but it's part of a standard screening process, versus somebody who goes in because they have PR bleeding, they have rectal bleeding and they need to have a colonoscopy. They are different. So screening things, as I've said, screening that is uncomplicated. And when I say uncomplicated, that means somebody goes and has a normal colonoscopy but doesn't get an infection as a result of the colonoscopy, or hasn't had bleeding as a result of the colonoscopy, or something else happening. If it's planned before consent, so that's back to what I was talking about with the hip replacement, it may or may not be an adverse event. So we're looking at these before consent time. If somebody goes and says, I'm waiting for my hip to be done, after they go into a study, and 6 months into the study, because you're doing a long follow-up study, they're back at their orthopedic surgeon saying, my hip is terrible, everything is really bad, I can't walk, I can't get up the stairs. That's an acute worsening of their condition, so that's going to fall into the adverse event category. If it's the same and stable and they're still waiting for their hip replacement, I would say it isn't, provided they haven't had a complication. So somebody goes in for their well-planned, long-waited hip replacement but gets a joint infection as a result of it. The joint infection is an adverse event, not the hip replacement. Am I losing everybody?
No.
I have, the cases should help, hopefully. I'm beginning to lose myself slightly, so I've spent far too long talking today. And as I've said, screening procedures, if the screening is uncomplicated, it's not an event. If the screening is complicated, it falls in there. A laboratory or an investigational abnormality. So this could be blood tests, blood pressure, imaging. Okay? If there's a new abnormality or a diagnosis, and it is a diagnostic result and it confirms you have a condition, it's probably an AE. So somebody who goes and has their bloods checked and they find out they're diabetic. One of the controversial ones is what happens to someone whose cholesterol is 5.1. Do they have high cholesterol or do they not have high cholesterol? Do they like the label of having high cholesterol or not? What's the current diagnostic criteria? All of those things. That's a judgment call in the moment. If you have a crazy abnormality, it's going to be an adverse event. That's particularly important in lots of clinical trials, particularly drug trials where they're monitoring for toxicities. The most common ones are going to be looking for liver toxicity, renal toxicity, and anything else that's stipulated. If you go and have no abnormalities, no clinical issues, and it's an investigator decision, so an investigator reviews every blood test you should have done as part of the clinical trial, and in my view, they should be documenting whether it's a clinically significant result or a non-clinically significant result. Often if you get centralized lab tests back, so if you take blood samples on a patient in a clinical trial that you send to a company as part of the study, you'll often get the result back. And everything that's normal will have nothing beside it, or may have nothing beside it. And then the abnormal ones, or the out of range ones, will have a box for you to determine whether it's clinically significant or not clinically significant. So if you have somebody who has diabetes in a study, and they have their diabetes bloods checked, and their bloods show they have diabetes, that's not a surprise. But if their diabetes bloods are absolutely off the Richter scale, it might be. And that's why it's a clinical decision. That's what I mean about the clinical significance improvement or the results there. Medications get messy, okay? These repeat a little bit. So if somebody starts a new drug after they go into the study, if it's because of a diagnosis, a complication, or a condition, it's an adverse event. So new blood pressure, new hypertension. If it's a preventive measure, right, or a primary prevention, it's not an adverse event. So a woman of childbearing age who goes in and decides to start a contraceptive pill, purely for contraceptive purposes, that's not an adverse event, versus a woman, the same woman who goes in who has significant gynecological issues that get started on a contraceptive pill as part of the treatment, that is an adverse event. You also have to make a judgment call as to whether something is an adverse event or not. So people who have diabetes who are on insulin, their insulin gets changed constantly, and should be. Every single change, whether you want to determine whether that's a refining of the management of the condition, and you can make a clinical argument that that's appropriate, rather than there's worsening of diabetes every single time somebody's insulin goes up, it can be documented and decided upon by the clinician. And if you're clever about this, you can reduce the adverse events that need to be reported because you're actually involved in overseeing the care of the patient. Drugs that are modified after consent, exactly the same issue. If you have a drug that's stopped or decreased because you no longer have a condition, obviously that's not an adverse event, right? So somebody who says, I no longer have high blood pressure, I no longer need that medication, That's there. If you have a drug that's reduced because somebody's gotten a side effect, that's a really important one, particularly if it's the study drug, but it could be something else. So somebody who's on blood pressure medications who gets kidney failure because of an issue or an interaction with drugs is a very different thing, and that interaction or that renal problem is the adverse event. Similarly, the increase of the medication, if it's refining or worsening of the condition, you can make a judgment call. And same issues with the drug stopped after consent. How am I for time? I'm okay? So my rambling over the dry ones hopefully will have stopped. I might have already described some of the cases too, spoiler alert, but anyway. So 30-year-old person who's consented into a study in February 2016 has a known baseline medical history of migraine. They're not on medication, they're not on any preventive agents. They had an episode of the migraine 1 week before the study visit that you've seen them while they're in the study. It was their typical migraine episode. They didn't see their GP. They didn't take any action. Their treatment wasn't changed. Is that an adverse event or not?
No.
Exactly. So look at the algorithm and say it's a symptom or diagnosis. It's known before consent. It's the same or similar to what went on before, and no action was taken. And that's how I think that goes down that algorithm. Same patient, except this time goes to the GP, headache is terrible, sends them to the emergency department, has a CT brain, has bloods, has all sorts of stuff done. Adverse event? No adverse event. Yeah, so it is an AE, because this again, it's still a symptom that's, or a diagnosis that's known before consent, but it's not the same as, I've skipped a slide obviously. It's not the same as it was before because the action was different. Because the action was different, there's a severity issue. The oral contraceptive pill I mentioned, if we talk about somebody who goes into this because they have gynecological symptoms, the reason they're starting the medication is for a worsening of a condition or a new problem. Somebody who goes into it because they want purely just for contraceptive reasons, where they fall on the algorithm is there. Regular visit to the GP, this person has their blood pressure checked, their blood pressure is high, their Ramipril is increased. Adverse event, yes or no? Yes, so you can hit this two ways on the algorithm. So one is they went to the GP for screening, their blood pressure was up, their medication was changed, or there was a worsening of the diagnosis. Or if we look at the drug modified after consent side, there's an increase in the drug because of a worsening in the condition, and that tells you it's an adverse event. GP checkup, this is a routine one, I've mentioned this already, this is the fasting cholesterol about 6.1. So the question here is somebody went for screening, many people would consider that diagnostic of hyperlipidemia, and that's why it would be an adverse event, but you need to refer to whatever relevant clinical guidelines are there. And you can get to it through this algorithm as well by going this way to say it's a diagnostic or a clinically significant result. It still winds up in the same path to say cholesterol is up. Because this would be a common one that would occur with liver function in trials in particular. It's often the main area of interest. A lady has a breast lump, notice it, goes to the symptomatic breast unit. They go and see her, everything is entirely normal. Is that an adverse event?
Did she have the lump before she consented?
No.
Yes.
Yeah, so the other thing to look at this is just because a clinician doesn't find something doesn't mean that the person didn't have the symptom. It might have resolved, it might not have ever occurred, but the person felt the symptom or felt the problem. So that still gets reported as an adverse event because it was after consent. Screening program I've already mentioned, it was normal mammography and there was no issue. So summary of what I've rambled about, and I'm trying to keep to time on this one, is I've talked a bit about the GCP definitions of adverse events and serious adverse events. Be really careful about reading the protocol for what is a event that is of special interest. So there are events, like I've mentioned this a couple of times, the pharmaceutical industry or drug trials in general would often have, if you have a doubling or tripling or a certain threshold for an increase in a liver function test, that has to be reported to them as a serious adverse event that has a whole series of expedited reporting requirements and all of that. Or you might be able to exclude things and say, I actually don't need to panic about this one. Documenting the evaluation of the episodes is really important to know what is or is not an adverse event. I very, very rapidly went through the algorithms that I have. And Siri has decided to shut me up. And the last thing I would say to you is probably the most important practical one, and that is if you think it might be an adverse event, report it. If you think it might be a serious adverse event, report it at the beginning. That doesn't mean it's going to stay as an adverse event. It doesn't mean it's going to stay as a serious adverse event when more information becomes available. Where you'll get done at site level or at coordination level by a regulator is if you have sat on something for too long. So the reason serious adverse events get reported really rapidly to the regulators is they need to be able to collate the information that's occurring quickly. Right, so pre-COVID, most people didn't know about this, but remember when the COVID vaccines came into play and everybody was paranoid about clots and platelets and all sorts of things. That was because all those events were being reported in an expedited manner to the regulator. They were collating the information quickly, making judgment calls on what's going on. If during the process, as more information becomes available to you, right, so if I'm at site and I hear my patient in the trial has just gone into hospital, I don't know why. The hospitalisation makes that a serious adverse event. You're probably as well off to report it as a potential SAE. As the information becomes available and say, actually, I found out they've gone in for a planned hip replacement, I don't think it's an adverse event. You can update the form. You can update the information. You can ultimately say it's not a clinically significant event when the total information is available, and you can... I'm very cautious over the verb I choose to use here. Withdraw is probably the best way. It doesn't get deleted, it just doesn't count, and it's in the audit trail in the data system. Versus, I sat there for 2 weeks while I was waiting for information from that hospital, and it turns out that that patient was bleeding to death from the anticoagulant I gave them in the trial. That's two very different things. So if you operate from a position of being conservative and report things initially, you're very unlikely to get into trouble. Okay, thank you.